Okay, hey, welcome everybody out there. This is our fourth research presentation from CBP Non-Profit. Again, I am Dr. Deed Harrison, president of CBP Non-Profit, our spine research foundation that's affiliated with loosely Chiropractic BioPhysics seminars and technique. The technique and seminars is where we train and teach doctors the ins and outs of corrective care with chiropractic biophysics, but our research organization is a true nonprofit research foundation. And I've talked about that in the past, so I'll defer you to the first couple videos that I did. Again, this is our historical slide in chiropractic biophysics nonprofit research. I forget to update it every week. We're upwards of about 156 peer-reviewed research presentations. We're going to go through an early project of ours that is from 1996. It's not exactly the fourth research publication that we've done in order, but it is consistent with the theme that we've been working through. In future presentations, I'll go back and pick up a couple of the projects that I missed. This one, to me, just has a little more impact in today's clinical realm with what the clinician faces. So without further ado, let's go through our fourth CBP Nonprofit research publication from 1996. This is out of the Journal of Manipulative and Physiological Therapeutics. My late father was the lead author on this one. Again, his former instructor, Dr. Steve Tronovich, myself, Dr. Deed Harrison, my dad's PhD advisor, Dr. Tad Yannick, and then the great Dr. Dan Murphy that most people know who he is out there. All of us contributed to this particular project, though it was my dad's personal idea. In reality, this is a literature review that provides framework for is correcting a patient's spine and posture towards idealized and average-based values, is that an appropriate thing to do in today's healthcare? Is it evidence-based practice? And you got to realize this was 19 years ago, so what we did is we reviewed the literature that we could identify up until about 1995 to provide a framework, if we could, to see is there evidence that's realistic and rational to support rehabilitation of a patient's spine. In this particular paper, there's several key concepts, and I'm going to go through a few of the most relevant points. The paper in itself is a little bit involved, but you can extract these key concepts out of it. To begin with, number one, in all fields of healthcare, you have to have a normal. Spine and posture is no different. If you don't have a starting position from which to judge somebody against or to, you don't know whether or not they're truly abnormal. This is standard practice in all healthcare. It doesn't matter if you're internal medicine or if you're external, right? You're going to compare patient values of any test to known standards, gold standards in particular. Well, when we talk about the spine, we have to look at what is an evidence-based spinal model, both from the front view and in the sagittal plane. And we start with the foundation of the Harrison Chiropractic Biophysics full spine sagittal plane model. Now you've got to realize that in the early days, the model was based on a piece of a circle. And this piece of a circle was a specific defined height over length ratio. So if I look at the height of a column called H, if you just watch my cursor here, H is the vertical height of the column. That's from top to bottom. L is the length along the curve of the column. If I have a curve, we know that the ratio of H divided by L is going to be less than 1. Well, the background of this model is the H over L index comes from the Delmas Index. And Delmas did some work in the 1950s and 1960s. He was a French anatomist, and he also had a math background. Don't know if he had a PhD, but it was obvious from his writings that he had at least a master's degree in math. And Delmas proposed a height over length ratio for the spine. The Delmas Index, the ideal was 95% height over length for the full spine from C1 to S1. My father picked up that model and said, well, let's use that as a starting position. Let's assume that the cervical curve contributes the same amount to that 95% height over length index. Let's assume that the the thoracic spine contributes the same amount, 95% height over length index. And then the lumbar spine does the same, 95%. Again, the Delmas Index was a full spine model. And so shown over here is the concept of the 95% height over length ratio, assuming that each region is 95% in its H over L. We get from C1 to S1, we get a total 95% index. Now the Delmas Index had a normal range. He was a realistic individual. He said, nobody's perfect. Let's propose a 0.94 to 0.96 range as within normal limits. And then, a couple little examples here. The straight spine, perfectly straight, no sagittal plane curves would be a 1.0 height over length index. And then very, very large hyperlordotic, hyperkyphotic, and hyperlordotic sagittal plane curves would be really, really short or really small in its height over length index. Really rare to even see somebody come that close to that depiction there. In reality, we found out in later work, and you'll see as we evolve, that the Delmas Index is likely a little bit too curved. Through the investigations that we've done in later projects testing this index from a validity point of view in normal populations, we found out that the index ranges from 0.96 to about 0.97, depending on which part of the spine you're talking about. However, back in this project, 1996, we didn't know that. So what we did is we used this model as a within normal limits model, and then my dad calculated both segmental and total angles of curve in each region, and that's presented in this particular project, using these normative data as a goal of care or a gold standard to compare a patient against. Now, there's controversy in chiropractic and spine literature with using this approach, and it seems strange, but the arguments are really interesting. They say, well, you know what, there's no such thing as a normal spinal model. There's no such thing as within normal limits for the human upright column. And the arguments still exist today, but back in the 1990s, one of the most prolific arguments was, well, you know what, people without symptoms have cervical kyphosis, or they have lumbar kyphosis. Therefore, a normal spinal model is not appropriate because it has no bearing on people's symptoms and health status. So I put a title up on this slide that says, do lack of symptoms equal health? Now, the obvious common sense answer is actually this should absolutely not even be a debate, because we know this. We know that there's many, many diseases in the human physiology that will have no overt signs and symptoms, but yet in the late stages, they'll show up as limited pain and disability, and then bang, you got a serious life-threatening condition and you die. And you didn't realize you had it going on. It was a silent process. I'm going to show you a table coming up right after this slide, or after this couple slides, that discusses that particular topic. But first and foremost, we have to address people without symptoms. How many of them have cervical kyphosis, for example? Now, one of the most popular studies that was cited, and still is today, was a 1986 project done by Gore in spine. So Gore in spine in 1986 looked at 200 asymptomatic adults. And of interest, Gore found 9% of them, that means 18 subjects, had a segmental kyphosis. None of the subjects had a complete cervical kyphosis. So number one, authors that have routinely cited the Gore study misrepresent the data from the Gore study. In fact, what they state is 9% of people that are asymptomatic had a cervical kyphosis. Not true. None of the subjects had a complete kyphosis. They only had segmental kyphosis. The Gore data, it's a cross-sectional study looking at one point in time in 200 asymptomatic people. Of interest, in 2001, he did a minimum 10-year follow-up of these subjects, and he showed roughly 10 to 15% of these asymptomatic subjects developed chronic neck pain. That's a different project. So we now see, hey, these subjects, maybe there's a reason that some of them develop symptoms 10 years later. However, sticking with the 1996 data, 9% had a segmental kyphosis. In these 18 subjects, their total curve still averaged 4 degrees. Okay? That's the Gore paper. It's often used to say, hey, see, cervical kyphosis is a normal variant, doesn't cause symptoms. So what I did is I tracked down some other projects. Number one, this project down here that's number 3, this one already existed at the time we wrote this project that we're discussing in 1996 from CBP. My father and colleagues presented some data in 1981 at the University of Colorado's Biomechanics Conference on Spinal Manipulation. Chung-Ha Soo, PhD, who is director of that department at the University of Colorado, headed and chaired this particular conference. My father and colleagues submitted a paper, and in this paper what they did is they looked at symptomatic subjects, and they collected a retrospective consecutive cohort of patients that were visiting his practice in Sunnyvale, California. He found 250 subjects over a designated amount of time, and he pulled these symptomatic neck pain subjects. Of interest, what he identified is 35% of these subjects suffered from different kyphotic deformities in the cervical spine. If you contrast that with the Gore data, you go, whoa, now I've got 4 times as many subjects with symptoms that have cervical kyphotic configurations as compared to 9% in an asymptomatic population that only had segmental kyphosis. So this contrast is very important to bring up. In 1997, we didn't have access to this particular project when we wrote this 1996 paper. Hardacker published a paper in Spine. Hardacker et al. 1997, what they did is they also looked at asymptomatic subjects. And I believe they did 100 asymptomatic subjects. They did a cross-sectional analysis. Well, what they identified is that 39% of these subjects had segmental kyphosis. Of interest, the Hardacker paper, many people do what I just did. They call it an asymptomatic cohort. However, when you read the methods of the Hardacker paper, you'll find out that these subjects actually were suffering from neck pain. They called them asymptomatic because they didn't require medication to control their pain. So this is really interesting. This is a true, like what you would call a mild, not quite moderate, but a mild neck pain population called asymptomatic for the purposes of a project, but what we identify is 39% of them have segmental kyphosis. Roughly the same amount as what my father and colleagues found in their 1981 project. Taken together, these two studies, Hardacker, 1997, and my dad's paper in the early 1980s, 1981, they identify 4 times the rate of cervical, segmental, and total kyphosis in symptomatic populations compared to the Gore data. Okay? Furthermore, the Gore data, when you actually pull up the information from the paper, and this is right out of the results section, if you will, this is table 3, and in the results, and you can see what I'm about to explain to you, is in their asymptomatic population, 1986 spine, Gore, they found that the cervical curve increases as a subject aged, which is quite interesting. The older the population was, the deeper the cervical lordosis was. Now, this may indicate that a deep cervical lordosis protects from symptoms as you get older. In contrast, what we find in neck pain populations, the older the subject is, the more reduced their cervical curve is. And there's other projects that we might go through at a later time that have established that. So using the Gore paper to say that, you know what, lack of or reversal of the sagittal plane curves is normal because it doesn't equate to symptoms is a very poor understanding and a very poor argument. And I've just refuted that. And that type of logical critique is what we did in this 1996 paper that we're going through of CBP Non-Profit. We basically proposed a model and provided a framework and refuted and brought up different arguments that would negate the use of this spinal model as a healthcare outcome. And as I alluded to, one of the most obvious explanations or arguments in healthcare, if you will, about lack of symptoms equaling health, it comes from just standard medical textbooks. And forgive the quality of this table, I cut and pasted exactly out of the paper, and it was an old scan of the paper, so you can see it's kind of skewed. But this is a list of conditions right out of a medical physiology and pathology textbook, that these conditions are known to cause serious complications and death, but they remain asymptomatic in their early states of the disease. So let's look at this. Cardiac arrhythmia, atherosclerosis, atrial fibrillation, benign prostate hypertrophy, breast cancer, and then let's skip over here. Emphysema, hypertension, Paget's disease, and let's go to the third column. Polycystic kidney disease, prostate cancer, renal failure, tooth decay. You look at this list and you go, it's obvious in healthcare that lack of symptoms do not equate to the health status of a patient. How ridiculous can we be? We're doctors. We should know better. To bring up an argument that says, oh, cervical kyphosis is normal because it exists in an asymptomatic person, that's like saying blindness is a normal variant of vision, right? Stupid. However, you have to bring it up, you have to discuss it. Forgive the tangent, I'm always good for one of those comments as I go. Another part of the project that we discussed or described in here, a framework for why providing or trying to establish a normal spinal configuration in a patient population. Another concept would be adverse mechanical tension on the spinal cord central nervous system, right? Now this topic dates back to the 1960s. Alf Bragg is typically given credit for the pioneer of this particular topic. However, there's a couple authors that beat him in the 1950s, specifically 1956 by Smith. However, Bragg is classically the actual pioneer because he wrote textbooks on this particular topic. And what we find out from his 1960 textbook and his 1960 article is that when you lose the sagittal plane curvatures in the spine, so you have a straight curve or a reverse curve in the cervical and the lumbar spine, it puts direct longitudinal tensile load on the spinal cord and nerve roots. It can also put longitudinal tension on the brainstem, cerebellum, and cranial nerves 5 through 12. So shown in this little depiction, and this is a hand-drawn picture from Bragg, and I'll show you an actual photograph of a cadaveric cervical spinal cord. What you see is when I flex my neck here, these arrows indicate long axis tension on the spinal cord and the cervical region, the brainstem, and the cerebellum. And then when you have a nice deep or marked cervical lordosis, you have slackening of the spinal cord, cerebellum, and nerve roots. And the total longitudinal strain in the Bragg papers, in the Bragg textbooks from 1960 and 1978, what Bragg identified is a 7.5 centimeter longitudinal strain of the whole column or the whole spinal cord when you lose the sagittal plane curves. Now, most of that longitudinal strain is experienced by the cervical spinal cord, and a great deal of it is borne by the brainstem. Now, you got to keep in mind that this is normal. This is normal movement, and this is important for your spinal cord to be able to have tension and slackening, tension and slackening. So if you go back and forth between the two pictures, you can get the idea that I would have a spinal cord under tension and then it would be relaxed. Well, that would pump fluid, oxygen and nutrients to and from the spinal cord. It would, what we call, perfuse the spinal cord. And the vasculature system and the cerebral spinal fluid system are responsible for the exchange of oxygen and nutrients to and from the spinal cord. The problem is, if you're stuck in a cervical kyphosis or a lumbar kyphosis, you don't ever get to relax your spinal cord. This is the problem. Now we have sustained longitudinal tension acting on the spinal cord nerve roots, brainstem, cerebellum, and cranial nerves 5 through 12. This can create some problems. Chiropractors call it nerve interference. Okay? We'll talk about this in more detail in a later project that I did in 1999. But the essence of it is, when you lose your cervical curve or your lumbar curve, or you increase your thoracic kyphosis, you're placing abnormal stress and strain directly on your spinal cord and nerve roots. And over time, they don't tolerate that so well. Things start to break down. What are the things that happen? Well, hey, symptoms can occur, but sometimes diseases can occur, right? Bragg's work, if you look it up, he suggested that this was related to different types of multiple sclerosis. He showed cases that it was related to Lou Gehrig's disease. He showed cases where it was related to, bowel and bladder dysfunction. And so, the list goes on and on. So it doesn't take, a big leap of faith to understand this is a legitimate mechanism whereby loss of the sagittal plane curvatures of the spine can really dramatically impact a person's health. And it may take a long time for these signs and symptoms to develop, just like the list of medical conditions we went through. So here's a picture from 1978 from Bragg's textbook, and this shows a posterior view of the cervical spinal cord nerve roots in the mid-cervical spine. I believe it's the C4, C5 nerve root level. And what they did is remove the lamina and the pedicle, and you can see the difference from the left to the right image, where on the left image, I have a nice cervical lordosis, or a deep cervical curve. My cord nerve roots are nice and relaxed, they're extended, they're rich, full of blood supply, and when you take that curve out, you get the exact opposite effect. You're placed under longitudinal tension, you can see strain in the nerve roots. The nerve root itself will make contact with the medial superior margin of the intervertebral foramen, or basically the top of the inferior pedicle of the superior vertebra. And that contact can create a shear load, and you can start to break down the nutrient supply to and from that nerve root. Okay? So if you take a look at that image, that's a graphic image of why you would want to restore somebody's cervical curve. You don't want your spinal cord nerve roots under tension. You'll have a reduction in the vascular supply. Just look at the size of the lumen from the deep cervical curve compared to losing the cervical curve. Right? So these are my blood vessels, my posterior spinal artery and veins, and then here's my radicular arteries and veins, or nerve root arteries and veins. So we go through that rationale in this particular project. The other thing that we go through is bone loading and degenerative conditions of the bone itself and the soft tissue, right? This is a very important argument, if you will, to suggest that sagittal plane curves are important for the health status of the spine. If you look at the loading situation in just the cervical spine, which is what we did in this 1996 project, our review of the literature, we find out that your cervical spine is actually a tripod. You've got the vertebral body and the disc as the front leg of the tripod, and then you've got the facet joints, the articular pillars, as the two back legs of my tripod. Now, of interest, the tripod, in theory, would support equal load on each leg. So you would have 1/3, 1/3, and 1/3. Now, in the cervical spine, there was debate about this. The debate was, well, my vertebral body and disc is a bigger cross-sectional area than my two articular pillars. They have a smaller cross-sectional area. So the debate was, well, the vertebral body and the disc then therefore should bear most of the load. In fact, that's wrong. As early as 1988, in spine, Pal and Shirk studied cross-sectional area versus cortical density and spongy bone density of the facet or of the articular pillars. They then also looked at that compared to the vertebral body densities. And what you find out is the articular pillars are dense, compact bone throughout. What that suggests is they're under very, very high compression load. In fact, Pell and Schur did a simple modeling experiment, and they estimated that 34% of the load is borne by each of the articular pillars in the cervical spine below C2, C3. So we have 68%, which is the majority, bearing 68% compression load bearing of the articular pillars compared to 32% of the vertebral body and the disc. Now this should make sense. When you look at this schematic, the center of gravity of the skull acts through the skull condyles. Even though the center of mass of the skull sits at sella turcica, which is in front of my articular condyles, right? The center of mass of the skull actually acts through the skull condyles into the atlas condyles. Now this load is going to be distributed downward as a pure vertical load, but it actually follows what we call a follower load path. Some of that load is transferred to the posterior aspect, posterior center of the vertebral body and the disc, and then the majority of it acts through the articular pillars. This follower load concept is well known today in engineering. It wasn't well known back when we wrote this paper. Okay? Many people thought that there's no way a cervical lordosis could support the entire weight of the skull because that curve would collapse under the load. Not true, and it's due to the design features specifically with the articular pillars. So when we look at the way this system's set up, you get the idea that having a cervical lordosis is critically important for load transmission throughout the cervical spine. There's other anatomical features that correlate to this as well. Specifically, if I did a cross-sectional analysis of the vertebral body itself, what we'd find out is the anterior 1/3, specifically right through here if you follow my arrow, the anterior 1/3 has very little trabecular patterns. It indicates that it is not under a lot of compression load in the anterior 1/3 of the vertebral body. This is why most compression fractures in the spine, specifically the cervical spine in this case, occur at the anterior 1/3 of the vertebral body. It's not designed to support that load. So here's the relevance of this. There's equations in math and mechanics, simple equations, where you can locate the center of mass of a curved column if it is a circular curve. You can locate the center of mass of the curved column by this equation right here. XC equals radius times sine of the angle alpha divided by alpha. What that will do is that'll locate the center of mass of a curved structure, right? Now, when you have a cervical curve, we've modeled it with a piece of a circle, by the way, so this equation fits. The center of mass sits posterior to the curved column. In fact, it sits a bit behind the apex of the curve, and it sits inside the concavity of the curve. Problematically, when you lose your cervical curve, shown in this schematic over here, A1 through A4 and then to straight, the center of mass, C1 goes with the curved column A1, C2 goes with A2, C3 goes with A3, and C4 goes with A4. What you'll see is the center of mass of that column or structure starts to shift forward, such that when you get a straight configuration, the center of mass acts inside the column. In this case, the cervical spine, it would be borne entirely by the vertebral body. It's not designed to do that. Worse yet is when you have a kyphotic configuration. The center of mass moves anterior to the vertebral bodies. The center of mass is now in front of the vertebra. There's nothing out there. It's the trachea. It's not designed to support compression load. When you look at this from a modeling point of view, you go, good God, it's not even a debate. The center of mass is in front of the spine where the trachea and the esophagus are. No kidding, this is abnormal. This is going to cause bone degeneration, disc degeneration, and severe spine remodeling. And this is what occurs. So if you look at this model right here shows you this center of mass is now in front of the column. Nothing's there to support it. That's going to trigger via Wolff's law stress-generated potentials and piezoelectricity. It's going to just create a charge separation. Remember, bone under load gives off an electric current for two reasons. Number one, bone is a crystalline lattice structure, and it is consistent with what we call piezoelectric crystals. When you put pressure on it, they give off an electric charge. Bone does that. The other thing is bone has fluid in it, and when you put pressure on certain parts of the bone, fluid is forced in different directions, and different charges will be expelled out, or different ions will be expelled out. Some of them will be positive, and some of the ones that are closest to the wall will be negative, and they won't slip out. So we get this charge separation by fluid flow that's called streaming potentials. The net effect is you get a negative charge at high compression areas in this case the front of the spine, and you get a positive charge at the back of the spine, in this case at the posterior column. Now negatives will create osteoblastic excitation, so the osteoblastic cells will now build bone. Positive will theoretically excite osteoclasts to chew up or tear down bone. This explains how we get degenerative changes in the spine. It has to do with mechanics, right? Certainly genetic and environmental diet plays a role, but your mechanics is a driving factor here. We are a mechanical biological organism. You're subject to gravitational and postural loads. Now, a couple quick projects that support this. In our 1996 project that we're going through here, and I'm giving you kind of a spectrum of what's in this paper, we didn't have access to this particular paper in 1997. It came out a year later. However, when it came out, we were like, yep, it's right on cue. 1997, Spine by Matsunaga et al. What they did is they looked at a cohort of post-surgical cases in order to identify why certain people were breaking down and degenerating after spine fusion and after surgery, and also why certain cases are degenerating to begin with. And what they did is they simply did what we would call a simple calculus analysis on their curves. They did a simple polynomial function, and then they took the first and second derivatives of the curve at different points along the column. Now the first derivative of a curve at a tangent point along a column, the first derivative gives you the slope. The slope is what we call the angle of curve. The second derivative gives you the bending moment. And then if I did the third derivative, which Matsunaga did not do, that would give me the shear acting on the column. You'll see that they did shear in a later project that I'm going to show you coming up. This particular project, what they did is they looked at a simple polynomial equation, took the first derivative and second derivative, and showed that their surgical cases were breaking down at the area exactly where the alteration in the slope or the angle of curve and exactly where the bending moment changed directions. Okay? And shown here is an example of that. So they did the first derivative and the second derivative. They should have done the shear. So they did a simple, and I said polynomial, sorry. It's a simple least square curve fit column, and yeah, it is a simple polynomial function. And basically what they showed is in a nice smooth curve, this column would not degenerate post-surgically. However, this column would. It can be a flexion or extension area that changes the slope and bending moment, or it can be a retrolisthesis or an anterolisthesis. Okay? So this is a very nice project. It's a longitudinal follow-up project. Now later, they came out and did this in 1999. Same authors, what they did was they're looking at a more advanced analysis, looking at true strains in the vertebral body and disc and the posterior longitudinal ligament. And what they did is they showed that at the area with the highest longitudinal strain, by looking at slope, bending moments, and shear, they showed that their cases post-surgically, these are the ones that A, developed disc herniations, and B, developed extensive or early forms of posterior longitudinal ligament ossification, right? So the soft tissues behave the same way the hard tissues will. Now, some of their cases had existing posterior longitudinal ligament ossification, and then what they found out is the areas of highest strain, that would accentuate it. Some of the cases had no posterior longitudinal ligament ossification, and what they found out is in these areas with the highest strain, these are the ones that developed posterior longitudinal ligament ossification. So you've got engineering papers that suggest, you know what, losing your sagittal plane curve creates and accelerates degenerative change in the vertebral body and the disc and the posterior longitudinal ligament. These are great papers. Here's the concept shown in graphical form. We developed an animation of this in later years that shows what happens visually when you lose your sagittal plane curves. And you know, you got to put all this information together. You lose the curve, you unload the cervical facets. Instead of bearing, 68% of the load, that load now shifts to the vertebral body and the disc. In a kyphotic neck, now the center of mass shifts outside the column and it's acting at the front. That's why these bone spurs start to develop, right? That's why your disc starts to degenerate in that area. I'm going to show you again. This is why your longitudinal ligaments will start to degenerate and ossify. It's mechanics, folks, right? When you look at this, this is direct evidence that supports a rationale for why we would want to A, assess a patient's sagittal plane curve, and B, why we would want to try to reestablish a proper amount or proper magnitude of sagittal plane curvature. All right, so that's kind of the key concepts in this 1996 paper of ours, the literature review. In summary, here's at the end of the day, this is what we were trying to argue and discuss, if you will. Normative data are essential for determining alterations in anatomy or physiology that may eventually result in named conditions. Without such data, clinical interventions by members of healthcare sciences, in this case chiropractic, lack any evidence-based outcomes to assess the effectiveness. We propose the use of this Harrison full spine model for the sagittal plane curvatures as ideal and average-based values, and for upright postural alignment, which we didn't really present, but it's in the paper. We discussed this as our evidence-based goals. In future projects, we hope to test the hypothesis that spinal alignment and postural alignment changes in patient populations that have abnormalities back towards normal will actually promote or improve health quality of life outcomes. And that's really the summary in this particular project. We said that that last statement, that's really what we must move towards. There's already enough information to support the framework and the rationale for why we would attempt to pursue this in a patient population. The mechanical engineering ideas, the spinal cord biomechanics ideas, soft tissue stress and strain, the fact that asymptomatic people aren't a good gauge of what true normal is, the fact that certain diseases remain, hidden until they're in stages. These are the rational arguments for why we would pursue an idealized and average-based upright human spinal alignment. And again, what remains to be tested, and we're still working on that today, by the way, is when we do this to patients, by reestablishing their postural alignment towards normal and their spinal curves towards normal, does that truly impact their health and well-being towards a positive manner or have a positive effect? We'll look at those, well in the future of this series of presentations. That's the end of this particular project. Hopefully you enjoyed it. The paper itself is a great read, and I just hit the key points. Hopefully you'll look that paper up and read the full text. I always say this, and I'll say it again. If you agree with some of the things we're saying in here, if you like what we're trying to do, if you like our vision, if you like our purpose with CBP Non-Profit, help us out. Chiropractic BioPhysics Non-Profit, it's a true nonprofit research organization. We follow all practical guidelines and legal guidelines for the use of human subjects in research. We have an independent board that approves the ethics of our studies. We have a great team of researchers. The thing that we need is we need members that support us. And members that support us, you can do that in one of two ways. You can directly go to our web link shown here, and you can donate any specific dollar amount to Chiropractic BioPhysics Nonprofit Research, or you can do it indirectly through Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation. I really appreciate the time and the attention if you made it all the way through the video, and I look forward to talking to you about future projects. Thank you.